So today we're talking about the cervical disc with an actual live patient to explain the dynamics and biomechanics of how the cervical disc works, how we diagnose it, what you can do to help it, and what chiropractic can do to help with that cervical disc. To get to that point, we need to talk about what the anatomy of the disc is. And so, given the most basic idea, we like to think of the disc as a round ligament that connects two bones together. The outside of the ligament typically are patterned in one direction. The next layer below it go in the opposite direction. So it forms a nice cross matrice between the different layers. Inside those layers, which we call annular rings, the very heart of that is what we call in Latin the pulpicenter, or the nucleus pulposus. The nucleus pulposus helps to dissipate force vertically onto the disc, acting as a shock absorber. This system works really, really well when we start to look at the human spine, and the head is based over top of a curve in the neck. If we lose this curve and we get what's called forward head posture, where the neck now is behind the head, increased pressure comes on the front part of the disc here and forces the nucleus pulposus to come backwards. Now the important part of this, and we need to realize, is that with the vertebra in the spine, which I will try and quickly draw for us here, the disc sits directly in front of the spinal nerve roots. You have to excuse my quick drawing here. But these would be the vertebra, this would be the disc, and this opening here is what we call the IVF, the intervertebral foramen, is where the nerve pops out and comes out of the spinal cord, or out of the spinal column. So if this disc comes back here and pushes on this delicate nerve root that comes out from that side, there's no place for it to go. It's trapped literally between a rock of the vertebra and a hard place, the disc. It often causes what we call radiculopathy. And radiculopathy means that it goes down and out away from the spine. If it goes out straight away, we'll often feel it on both sides. If it goes out to one side, you'll feel it on that side. The different ways they characterize it, either protrusion or bulge or herniation, just defines the shape of the herniation. If it blows out all the way through, that's a frank herniation. If it bulges out, obviously that's what they call that. A protrusion is a broad-based one. We often see it either coming straight back, is what we call central, off to the side is what we call a paracentral. Those are the only three that we're really concerned about, because if it goes forward, it goes into a ligament on the front side of the vertebra that has no nerve endings in it whatsoever. So we really, if we were going to choose a herniation, we'd like for it to go forward. Or we'd have it even herniate up into the vertebra itself, which we call a Schmorl's nerve. Are you guys tracking with me so far? Good. So I'm using some big terms, but the real bottom line is that we have this fluid jelly-filled donut here that has a weak spot in the back. We don't want the jelly donut to pop out and go this way back here. So we have to find some way to get the jelly donut, get the jelly back into the donut, or the shampoo back in the bottle. The best way to do that is to create a negative pressure within the disc. And so if we're looking at the vertebra, what we want to do is we want to induce two motions. And I'll just make them blocks here on the film, or on this piece here. The only way to get this to stop bulging back this way is to pull them apart. And so we induce a motion called traction, which pulls the head off the body. Not entirely, that'd be bad for you. That's one method to do that. The next method would be to combine that with the action of extension, which is arching the neck into the curved shape that we just so desperately want. When we start to open them up here, that creates a negative pressure and sucks the disc material back inside too. The most important thing that we have to drive home to our patients is that this is a structural injury. It's a structural injury, and it has a structural fix. There's no amount of acupuncture or drugs that will help this. It is what you do from day to day that affects this disc. The problem with the disc, really more than anything else, other than it being a structural injury, is that it doesn't have a blood supply, or a very good blood supply whatsoever. So most of the ligaments in our body don't have good blood supplies. When you damage them, it takes a long time for them to recover, if at all. And so the damage to discs is cumulative over the course of your lifetime. So the sooner that you intervene with this, the better the response. The ideal, or I shouldn't say the ideal, the average patient that has this is about 35 years old, and we see them up to about 65 years old. And the reason we don't see them in people who are younger than this is that their disc has not sustained enough damage to start to bulge out. The reason we don't see it in people who are older than this is that the disc dries up over time. And so at one end you have this undamaged grape over here, and at the other side you have this shriveled raisin. This way the outside membrane is intact, this way there's no way it's going to bulge out. So somewhere in through here we have a damaged grape situation. Thankfully, the edge of your grape is much more durable when we're talking about the disc. And so if we remodel the disc, then we have a chance of getting this off the nerve. The problem with the nerves is that they control and coordinate every structure and function in the human body. That is the premise of chiropractic, that the neurology dictates what we do. The nervous system controls and coordinates every structure and function in the human body. That's important to know, because when you start to put pressure, direct pressure on this nerve, you literally affect where this nerve goes and the end organ it affects. So if we're looking at a level, say C5 and C6, just for kicks and giggles, I'll go ahead and show you where C6 innervates. It's half of this finger. I should do this with a marker. This would be C7 and this would be C8. These are dermatomes in the hand. So if someone comes in and they have numbness or tingling in these three fingers, that's C6 that we often see. If they say this finger is numb, don't take that personally. That's C7. And if it's these two, then we start to look at C8. Each one of the levels of the spine is the problem that we're looking at. It helps us identify where the problem is. So when someone says they have it on both sides in these fingers, we know that we need to go to C5 and C6. Now it can be fixed forward and up on the spine, but that gives us a really good idea as to where we need to go with these. So chiropractic looks to help you out really simply. We start to give you traction and extension exercises that separate the disc and drive the disc material forward. It's really that simple. In our office, we use what's called an A to P adjustment, which means front to back. And the A to P adjustment really increases the curve that we're looking for in the neck. I don't know if you've ever tried to drive a nail before, but if you drive a nail and you take a hammer and it's straight, it's pretty easy to get it into the wood. But if you take a nail and you bend it, and then you try and drive it into the wood, it doesn't work so well. Why?
Because of the curve.
Because of the curve. It dissipates the force and drives that force this way, just like a bow and arrow, right? And so, if you start to bend that more and more, you have more and more force that drives forward. We're using that concept to get the disc material from here to there. So oftentimes we'll hear patients say, I have a bone on a nerve, or chiropractors will say that. Very rarely is that true. But when we see a disc injury, we know that there is a space-occupying lesion, the disc, on top of that delicate nerve tissue. And since we know that the nerves go out to different areas, it's going to affect things downstream. Now the C5, 6, and 7 start to form what's called the cardiac plexus. What does cardiac mean?
Heart.
Right. So these are nerves that literally give you the energy to fire off your heartbeat each time. It also gives you the motor energy to your hand. And so that's kind of important stuff. It's interesting that when people have heart attacks, where do they feel it?
In the arm, hand.
In your arm and the hand, right? And so we start to see how these nerves overlap and relate to one another. So in our office, we really drive home the actions of traction and extension. This is a typical film for a patient who has a disc injury. Unfortunately, discs, I think we talked about this last time, they don't show up on our x-ray film other than black spots in here. They're black dark spots. Those dark spots are soft tissue, so the x-ray goes right through them. The thing we need to do to see these is an MRI. Now we'll pull out an MRI for you later. We'll show you what it looks like. If this doesn't get better in the first 2 weeks of your care here, or if you start to notice that you're getting weak because we're starting to push on the nerve so it gets all the way pushed back here, and you can't pick up a coffee mug, or you notice you're dropping things, or it's hard to squeeze things tightly, that would be the time when we'd send you off for the next imaging. Okay, so we always ask for 2-3 weeks for the patient of aggressive care so that we can see if we can make a change with them. You're at this phase where you still have full range of motion of your hands. You can do whatever you want to. It's this crazy numbing thing that you've got going on, but it's in such classic distributions that we already know what the problem is. Now, I should tell you, you're not alone. 4 out of 10 people, 40% of the population walking down the street has a disc injury. 5 something. 5 what, Dr. Lee? Okay. Dr. Lee has something he'll add to this after this video. But you're not alone. C5 and 6, which is where we think you have the problem, is the 3rd most commonly herniated disc in the human spine. So it starts down the lumbar spine, probably because where the discs are up or stress on them. But largely we see C5 and 6 because this is where we see the most flexion and extension, forward bending, backward extending in the spine. And so we often see these after untreated car accidents. You might have mentioned to me that you were in a 50-mile-an-hour car accident. That would be an excellent choice if I was going to order up a disc injury.
Sure.
At least it'd be a good appetizer. So starting up with our care, expect that when we have this talk, we're going to recommend some aggressive care up front. The reason we do that is that we want to see the biggest change up front. Just like pushing a Buick or anything that involves a big task, the more momentum you can build at the beginning, the less effort you have to do down the road. And so we often recommend this short course of care, of aggressive care, so that we can get you on the right track. If it doesn't work, it's okay. We want to know what's going on and why it doesn't work. That's when we'll send you out for more imaging. Imaging is expensive. It runs about $1,000 for the surgeon, for the MRI, up to $1,200. So it can be pretty pricey out of pocket. X-rays and chiropractic, if you look at that, relatively cheap on the grand scheme of things. So I think chiropractic is the best treatment for this, and that's what I'm going to recommend for you. Now, do you have any questions?
You covered it pretty well.
Okay.
Just make sure my tingling and numbness goes away.
Absolutely. Now, Dr. Lee, is there anything that you would like to add to this? Why don't you sit over here and I'll film you.
At this moment, no.